talking about mental health care during war, during the wartime, during the operations, because we tend to kind of focus a lot on the periphery, and as mental health professionals, we try to do things. And for the first point is, I don't want to pretend that because I was in Afghanistan, because I was in Rwanda, because I was because somebody's been somewhere else, that they understand exactly what's happening in the current circumstances. In Afghanistan, we fought an expeditionary war, so our families were safe at home. We were in Afghanistan. We had 100% air supremacy. We had a very large NATO army compared to who we were fighting. So there are differences that are extremely important when the brave men and women of Ukraine are fighting for their own homeland with a fairly substantial enemy. I do think that there's principles that apply, and I'm going to try to sort of get this point across, and some of it's going to be a bit repetitive, but hopefully we can stimulate some discussion. I've started the first slide with sort of I don't know, certainly a Canadian military, and some militaries use the same idea, which is sort of the bluff concept, sort of the bottom line up front. Like, what am I ultimately, hopefully, what I want to impart upon you guys, colleagues, is that the role of health services during a war is to conserve manpower and operational readiness, right? And I just think that the health of people is important, making sure people don't die is important, making sure that surgeons are there, all of this stuff. But the real emphasis on why we exist as a health services is to ensure that people are ready to fight and win the war. The worst health outcome and the worst mental health outcome is going to be losing the war, right? I think that's one of the points I want to make. The other thing is as much as I've spent my entire career, to use the expression, I'm a psychological ambulance, chaser. My whole career has been in trauma, in PTSD. When we deploy, when we look after soldiers, it's not all about trauma. It's not all about this. And I'll show a little bit about what we saw when we were in Afghanistan. The other point is that mental illness, it's really important for professionals to be involved if it's severe. But mental health, just like physical health, is a leadership responsibility. We could share, we can advise, but at the end of the day, it's the leaders that are responsible for how healthy and strong physically and psychologically, soldiers are. And then the last point that I want to try to make is that we have a lot of emphasis on what's going on today, the mental health of the men, the women, the civilians, the military. But the real need is going to be later for years and years. And we do need to start thinking about what's going to happen after the fact. So I was, in 2006, 2007, I was sort of fortunate enough to be in Kandahar, which is, looking after sort of Canadian soldiers, veterans, and, about 1,600 Canadian troops at a time went there. But the camp in Kandahar, for people that have been there, was an old airport. So I was the only psychiatrist in the southeast area of Kandahar for some time. And it was quite a challenge, quite a challenging experience. Culture shock, some interesting, beautiful parts of the country. There was also the exposure that soldiers had. So luckily we did have air supremacy, as I mentioned, but getting out, foot patrols, the vulnerability of sort of being in places where there was the constant threat. Within the communities, there was always the threat. And what I often try to say is even if, nothing happened here, the heightened amount of anxiety with all the things moving, for hours and hours and hours, people are standing there in 40, 50 degrees Celsius heat, worried about what could happen. If they fail their mission, everybody on patrol might not have a vehicle to get back to the base at night. So there's the constant threat. I often use this picture just to sort of show the physical and psychological burden on our soldiers, because, on top of the psychological stress, there's carrying weight, they're often dehydrated, they're tired, they're sleep deprived. So all of the perfect settings for this. For us as Canadians, the big shock for us after years and years of peacekeeping, like the Dutch and our other colleagues, is how real the threat was, the loss and losing people. The grief that gets involved is not just always about trauma, but it's loss and it's the guilt of sort of surviving when your colleagues haven't. And the exposure to sort of children, the collateral damage, which again, for us as Canadians, it was, you know, little Afghan children, and of course for the Ukrainian soldiers, going to be some, you know, victims of their own culture, which may be even more pointed, but certainly it's the innocents that get caught up in conflict that sort of have a psychological impact on people. You know, the ramp ceremonies that we used to call them, we moved them at night, because when we did them during the daytime, the Taliban used to start sort of rocket attacks when they saw us all gathering. And you could see how, you know, it's a Canadian dead soldier, but you can see our American colleagues and British colleagues, everybody would come out and stand. So we did, sadly enough, we got used to it. We'd wake up at 2 a.m, we'd go out there, stand there, then go back to sleep. And that was the idea. And I just sort of looking at the people's faces, and you can just see how they've been impacted by these losses. So to provide care, and Eric, I can't see the chat room, so if there's questions, please bring them to me. You know, we had a mental health team in Kandahar. We had a couple of mental health nurses. We had some social workers, you know, psychiatrists. You know, our colleagues from other countries. We were a big role 3 hospital. The U.S. sent colleagues. The UK sent also. So we had a team. Here's sort of our team. You can see our American colleague, and these are mostly Canadians here. But I think this is an important slide that I want to take some time for, and you know, we've got a colleague that's deployed, but I think the really important point is when I went there in 2006, the first time, I expected it to be all trauma. I expected it to be, you're going to just see a bunch of people exposed to trauma. They're going to have this. But the reality is it was a mixture, and I've got a little bit of data to support this. And so first of all, a lot of times people had pre-existing illness. And I know in one of our previous these meetings, people talked about somebody that has PTSD and concussion and is now fighting. So sometimes what happens is people have pre-existing illness, depression, PTSD, addiction problems, and they surface when you're in theater or during the deployment, during the operations. Sometimes people know about the illness, you know, hey, I was depressed a year and a half ago, I thought I was better, or I thought I was better with the PTSD. Other times it's unknown, and we uncover it during, and we may have to start treatment, we may have to do this. You know, the other thing that's really important is again, why it's important not to just have your trauma lens on, but have your general psychiatrist, psychologist, mental health professional, is that a new disorder may emerge. You know, you could take, you know, 1,000 people to Hawaii on a holiday for 6 months, beautiful setting, safe setting, and somebody's you know, bipolar illness or schizophrenia may emerge. So we may see the emergence of a new disorder that may or may not have to do with the deployment, may or may not have to do with it. But certainly if somebody has a risk for bipolar disorder and you stress them, you sleep deprive them, we may see the emergence of this. So it's quite interesting how much, you know, in the American, British, you know, Canadian troops, we saw the emergence of illnesses like bipolar disorder, you know, nothing at all to do with that. Now, trauma-specific presentations, of course, you know, combat stress, acute stress disorder, PTSD emerged, and they sort of came in waves depending on the combat tempo. You would see, you know, a major offensive happen, physical injuries, trauma, mass casualties, and then the wave of those would occur. And the other thing that does occur, which again, you know, in retrospect, not surprising, but surprising at the time, psychosocial issues, things going on at home, communication. You know, somebody phones their spouse, and the spouse says, you know, the marriage is over. I'm tired of this. I'm tired of worrying every day. Or, you know, your kids are not doing well. And so sometimes we even did, you know, marital counseling from, you know, 15,000 kilometers apart, with the spouse sitting in the base in Edmonton and the social worker being with the soldier in the place. So I think it's really important when we're looking after troops, when we're looking after people, not to have just that singular lens of it's all going to be trauma, it's all going to be PTSD. So what we saw, just quickly, a quick example, some data, you know, just quickly, we saw 56 patients, Canadian and American, for example. We saw Romanians, we saw people from Australia, many other countries, but But the Americans, 9 of them had pre-existing illness. Canadians 11. So again, nothing to do with this specific deployment per se, but just a reemergence of it. The combat stress, the traumatic stress in a fair number of the Americans, but even more of the Canadians, and other mental health illnesses were prevalent. So I just think it's really important to keep in mind that we're dealing with a population, and the population is exposed to trauma, but they also have other human conditions and illnesses that are present as well. When we went into theater and we surveyed sort of in one of our task forces, we came up with this kind of number when we surveyed sort of, I think it was 400 or 500 people. We found depression was sort of, this is kind of to emulate the MHAT, the surveys that the Americans were doing. Significant amount of depression, sort of general anxiety, and some trauma. So all of the illnesses were present, and again, just reemphasizing sort of that broad approach when we do assessments without making assumptions. So many people have seen this, and this is sort of when the Canadians, we put together our Road to Mental Readiness, some of our mental health and resiliency training, working with sort of the Americans, the Australians, and others. I think this was kind of an interesting approach to take when you're in theater, is to not see illness as black and white, like you're either healthy or you're sick, because in a war zone, when you're sleep deprived, when you're losing your colleagues, you're under constant threat, you're never going to feel perfectly normal, but when are you ill? And so when you look at this idea, what we did is we created this concept of, and the same thing applies for physical health. There may be times that I feel great. There may be times that I have a sore back. There may be times that I have a headache, but when am I disabled? When am I ill? So the idea, just going across, and we've created this in our training right from basic training. And what happens now is soldiers will come in and say, hey doc, I was yellow for a little while, but now I think I'm kind of getting orange. Or you'd have a warrant officer bring in 7 or 8 of his soldiers saying, I think some of my guys are in the orange or the red, and so it's just a way of not having people diagnose themselves, but just ideas like, when you start to, and most people in a war zone, most people that are coming back after a deployment will probably be in the reacting. So there'll be some irritability, there'll be some nervousness, some sadness, maybe some difficulties with sleeping. All of these things are part of the normal process. It's when they start to come over here and down to here, that's when you start to get a little bit concerned. And you could see how this can impact functioning, how this can impact, operational readiness. From a physical perspective, you're healthy. Reacting might be you have a sprained ankle. Injured might mean, you've got to actually stop and raise it, and 11 and ill might be fractured. So you're not going to treat the fracture yourself, but you might be able to treat the reacting with first aid. So the idea of just thinking about things on a continuum, and the idea really be in terms of functioning, and really intervene if we feel like it's going to stop the functioning. The model, again, as we talked about, normal functioning, reversible distress, severe and persistent functional impairment, and clinical disorders. So again, I think it's really important as a clinician in a war zone to know when you need to intervene. If somebody's reacting, hopefully their buddies, their leadership can do it. It's when people start to get further on that we may need to provide some intervention.
Rakesh, if I may,
Yeah.
can you go back one slide? Because
Yeah.
in the red, sometimes it's also referred to as the sort of the spiritual domain, like losing hope, or
Yeah.
believing that there's no end to this, and
Yeah.
giving up your morality. Could you speak to that?
Yeah, well, again, you could see that in the yellow, you could see that all the way across. But again, I think that from a, I put a lot of this stuff during deployment into the leadership domain, into the peer domain, because I think that as soon as you start getting involved as clinicians, we start pathologizing things. So I think that if people have poor morale, or there's morale and there's moral, of course, if people have debates, then really a good leader, I'm going to talk about leadership in a minute, a genuine leader that's open to discussion, that's this, if somebody's wondering about the futility, what are we doing here, this kind of idea, I think a colleague a leader is in a much better position to help people, to sort of motivate them and to address, morale and moral, the two separate things, than a clinician. I think afterwards, maybe clinicians, you and I, 10 years after the war, we might help to put things in place. But if people are stuck during an operation, ideally, transparent, genuine, authentic leadership should help people with that. So I think, so again, just to sort of summarize this section, I mean, when we talked about when I first did my basic training as a general duty medical officer, long before becoming a psychiatrist, the idea of the role of health services, during operations is to conserve manpower, right? It sounds terrible, it sounds bottom line, but at the end of the day, the idea is to make sure we have enough people to be able to do the mission, to be able to do the fight. And Eric and I know that whenever we're applying for money for NATO, whenever we're asking NATO, can we have this meeting, can we do this? All they care about is the operational readiness. Will this help soldiers being able to do the fight? Will this help? Resiliency, we care about resiliency as mental health professionals to make sure people don't get sick. The commanders, the leaders of NATO say, hey, we can create super soldiers. They can fight forever. They won't need sleep. That's how they think about it. And the interesting thing that if people are historians, and there's some great paper, Edgar Jones and some of the folks at King's College, is that for the turn of the century, so again, from the Crimean War, again, Crimea, which is your history, Florence Nightingale, all of this, from that era, the British, who were really leading things, realized that it's the doctors of hygiene. It was before antibiotics, primitive surgeon. But at the end of the day, most military physicians, up until about World War I, were doctors of hygiene. And what they realized was, in fact, the soldiers deployed tended to live and have a better mortality than the soldiers at home. And they just realized, because on deployment, we pay attention to where the latrines are, where the water is, and we try to keep people healthy. So the idea way back, military physicians used to be doctors of hygiene in the sense of making sure people don't get sick so that they're able to fight, right? So I think that's the thing. And as a mental health professional, we fall into that role as well. I'm going to talk briefly about sort of what kind of approaches that we've taken historically, and then give an example of one of the encounters that we had. And the PI principle, or PIE's principle, that came out sort of in the French, and then the Americans, British, everybody used it, and it's still within most military approaches. It's in most military textbooks. So the idea is, if somebody, let's say back to our old slide, if they're in the yellow, they've gone into the orange, they're having trouble. You bring them back a short distance. You don't take them all the way back to the home country. You have some rest. You don't treat them as patients. You give them simple rest, sleep, food within the sound of battle, and then get them back fighting again, right? And the idea was that this was good, and it kept people fighting and all of this. And nobody looked at it in a very scientific way. I remember Sandy McFarlane, our colleague from Australia years ago, said, keep in mind that principle there wasn't for the well-being and the mental health of people. It was just to make sure that you have soldiers fighting, you don't have trains full of soldiers going back to England and to France. But when Edgar Jones and the people at King's looked at it, doing this approach, which interestingly enough is the same approach that we did in Kandahar, most of us, we brought people back into the camp, we let them have showers, have food. When they looked at the British thousands and thousands of soldiers, only about 20% of them returned directly to the combat units. Most of them ended up in hospital, convalescent, they were doing base duties. So forward psychiatry, which is this concept, wasn't really effective in returning combat troops to fighting units, but they just sort of kept them in support roles, which maybe allowed more soldiers to go forward that would have been in support roles. So that's the important point, is the sense that it didn't really ever do what we thought it would do, bring people back for 2 or 3 days, then put them forward again. And then again, but what about long-term, what was the impacts of this? In World War II, another idea was when Omar Bradley started to say, hey, stop calling this a disease, call it battle fatigue, call it stress, give people a bit of rest, and they'll be back again. So there's always been this idea of not to pathologize, of not to call it a disease. And and the idea basically is to do this. So I'll give a brief example of a Canadian example of this, where we had combat engineers, like everybody has, the people that are responsible for for cleaning mines and for making sure after vehicles have been blown up. So we had in 2006, we had a group of combat engineers that were involved in lots and lots of deaths, lots of people. They had lost a few of their own soldiers. Sometimes they thought they had cleared mines, but the Taliban put mines back in place again. So they were showing distress. Their boss came in and said, "Hey, doc, I think my guys are stressed out." And so basically we applied kind of a pies principle, or 8 of them. I didn't want to stigmatize any of them by picking the 2 or 3 that were the sickest. And I kind of said, okay, all of them for 3 days, they're going to come on the camp, they're going to eat some pizza, they're going to go to the gym, they're going to sort of get some sleep. This kind of idea made complete sense. Everybody's okay. Next day, the commanders came to me and said, "Doc, I know what you're doing. I agree with what you're doing, but I need some of them because we're doing a major operation and the infantry can't move without the combat engineers." So of the 8 people that I had promised, 3 or 4 days, you're going to be inside the wire, I had to pick 4 of them to go back out to the fight again after 1 day. And it was really interesting. My junior colleague, who was a medical officer, was quite distressed over it. And I said to him, "Look, in my head, I don't think all 8 of them needed it." And so we basically went and we chose 4 of them went out, and the mission was successful. Nothing disastrous happened. But just the reminder that at the end of the day, the operational necessity, completing things, does sort of trump and does beat out our sort of desire as clinicians. I didn't feel that they would be unsafe if they went out, but it did go against what I had told them. So just an example of where those things become more important. And again, I'm going to just switch subjects a little bit, and we can certainly have some discussion as colleagues later on. But I think, mental health is not a clinical responsibility. And this is something I know, Eric, a lot of us have had discussions over beers all this time. It's just the idea that it's a shared responsibility for mental health and mental illness. And I think the importance of peer support, people have to sort of look after each other, just like in sports, just like in everything else. Authentic, genuine leadership, when leaders care about their soldiers, care about what's happening in their homes, understand who the people are, and are able to explain things when people are distressed. I think after an operation, after a bad day or a good day, sitting together with the soldiers, talking to them about what's happened today, what was good, what was bad. I think that's the important thing. As mental health professionals, we're not going to be as close to the troops as we are. The other thing is leaders have the responsibility for education, for training, for equipment, for morale, rest, rotation of troops from the front. So it's really all of these factors, the confidence and competence that they have in the fight is going to be a leadership responsibility. So I think it's really important. Mental illness, maybe we have a bigger role, but mental health for sure, just like physical health, is a leadership responsibility. Going back to our continuum model, we talked about, chain of command versus health services. And one of our former Surgeon Generals actually drew that dotted line. So if you think about over here, when somebody's very, very healthy, there still is a health services role. We might be doing medicals on people. We might be doing vaccinations. We provide them eyeglasses, maybe some mental health education. And then when they're over here and they're really, really ill, maybe the health professionals take a bigger role, but the chain of command should not completely drop them either. They should still be visiting them. They shouldn't be abandoning them. So I think the idea of the shared responsibility is there, but day to day, health services is more in the background, and at the extreme end, health services plays a bigger role. So I think it's really important to think about. And triad, what we talk about, triad is we talk about leadership, the patient or the soldier, and the health services, the group of 3.
Hey, Rakesh, let me intervene. I'm sorry if I'm interrupting,
No,
but
it's okay.
it's really important what you said. I think about leadership, but leadership also needs to sustain the operations. So how, could you give some ideas on how to enable the leaders to sustain the mission? Because there can also be breakdowns or cracks in their mental
Yeah,
health?
well, I think leadership is funny because we have so much data, right? PTSD is higher in people who have perceived leadership as poor, like people. And the problem with leadership, again, I remember once we were asked by the COMEDs, the generals, to say, why do you keep talking about leadership? What do you mean, right? And the problem with that, of course, is that even bad leaders think they're good leaders. Right, so it really, to me, it's, I mean, when I say authentic leadership, genuine leadership, I mean genuine caring. Like it's not like it's Thursday afternoon, I should walk around, pat people on the back because I haven't done it. It means knowing your people, because you have to know people at the baseline. Because if somebody's there every night at 6 o'clock around the fire having a coffee telling jokes, and you notice that they're not there anymore, you have to know them at baseline, right? So again, it's not always possible during war because new people come in, but you have to integrate and welcome those new people. A good leader interviews, and again, leader is junior leader, senior leader. I'm not saying the general has to do this, but at each level, when a new person comes in, make them welcome, understand who they are. You've got to know who has young children, who's got parents, what part of the country they're from, all of these kinds of things, because you have to anticipate what's distressing for people. I also think that at the end of an operation, at the end of a thrust, you sit and you sort of air grievances. How was that today? And a really good leader says, yeah, I was scared too. You give permission to the young soldiers to be afraid or to be this way, to remind them of the mission, to remind them of their duty. And so I just think it's really important. I've got a slide later on that talks about good leadership. But I think that as mental health professionals, we need to sort of, we need to be there sometimes as a psychiatrist, quite often. And you remember, as Colin McKay was my boss for a number of years. I mean, sometimes we might be there to have the coffee with the leader when the leader needs to vent themselves, right? So, because that can be a lonely position. But I think that the whole hierarchy of leadership, right back from the Roman and the Greek era, the leaders, the charismatic leaders, the leaders that set good examples are the ones that tend to be more successful, but also they have less casualties, physical and psychologically. So here's the leadership responsibility on perfect cue. Lead by example, get to know your personnel, foster a healthy climate, identify and resolve problems early. Avoiding things isn't going to help. Demonstrate genuine concern, provide opportunities for rest, because you're the one. I remember in Kandahar, we had a lot of young soldiers that played video games at night, but the leaders would go in and turn out the lights at 11 o'clock at night, get the rest, so there's a real responsibility. Stop, drink water, stop, eat, look after your feet, all of these kind of things that basic soldiers do. Watch for behavior changes, adjust the workload as required. I mean, it really is the leader that sets the tempo on, right? And the leader has a responsibility both directions. You always have to look at the people that are above you, your own bosses, but you also can't neglect your troops. So you have to have loyalty both ways. And I think that's what it is. And then if you start to notice people that are struggling more, then you know what the mental health resources are, demonstrate the concern, respect confidentiality, minimize rumors, all of these things. There's sort of evidence behind each of these. But this is where I used to love it in Kandahar, where a leader used to walk in and say, Doc, I'm really concerned. My 8 guys, would you see my guys? And I said, yep, absolutely, I will. And you're first. So he set the example of being the first one in to see the shrink, and then everybody else did as well, right? So I just think that that's the important thing. We can't, as mental health professionals, start running around in a battlefield trying to identify people. It really needs to be that trusting relationship with leaders. So I think this is the kind of things where we are teaching our leaders, and it's not mental health professionals that are teaching this stuff. It's other leaders are teaching leaders of how to sort of, be good leaders and at least get that minimum level there. We've talked about our road to readiness, and so some of this stuff comes from sports, sort of goal setting, visualization, self-talk, and you can sort of instill this, and this is coming from positive psychology, performance psychology. These are the pieces that we teach, and so the leaders can sort of reinforce this stuff in folks themselves. And the idea really is, and the recovery piece, I think, is extremely important. Even in war, even in operations, no human being, no vehicle, nothing can run 24/7. And so it's this idea, and you might have to push back a little bit to make sure that people have the opportunity to recover and reflect and then prepare for the next push. My last point, I'm gonna end in a couple of minutes. I think after the war is the greatest need, and I think this is the point that I can't emphasize enough. I've had the privilege of going to the war memorials on November 11th and seeing some of the veterans from World War II that have like 100 medals on their chest from all the operations, and you just see the sadness that they feel. And so I just really think that it's important for us to sort of talk about what we're talking right now. It's interesting, we're talking about the hot topic, and maybe in 7 years it won't be a hot topic anymore, but there are going to be people that are suffering. So I think we need to sort of really emphasize that point. A little bit of data. This is thanks for Sandy McFarlane, our colleague from Australia, sharing. Butler is a person that analyzed, a surgeon, I think, that analyzed all the veterans' claims from the Australian Defence Force after World War I. And basically between 1924 to 1940, interestingly, after World War, a few years after World War I, all the way up to World War II, the pension rates for neuroses, for difficulties, psychological, after World War I kept increasing every single year. So just because the war is over doesn't mean the psychopathology is over. Not only does it mean it's not over, it lasts longer. So this chronic sort of pain, mental illness, inflammation, heart disease, all of these different kinds of things persist for many years. And we called it the war to end all wars. By 1938, 250,000 Australians were assisted through war pensions, and just slightly less than all the people receiving old age pensions in the US. So their 10% of their population that served in the war superseded all the 90% of the country in that way. And there was clearly a 13% greater mortality if they had fought in the war. So this idea of, there's no doubt now that war is not good for your health for a lot of people. And it's not just about lifestyle, about smoking, it's about heart disease, diabetes, all of the different sort of chronic pain kind of illnesses. And just the last point again is that, in 1929, so 10 years after the war, more pensions were granted in the US for psychosis than in 1918 to 1922. So more people after the war came forward, and again, the statistics speak for themselves. So I just think it's really important for us to think about long-term when it comes to this. And I'm going to stop there and address questions and so that my colleagues sort of take over if there's anything else.
Sure.
Thanks very much, everybody.
Sure. Thank you, Rakesh, for as always a wonderful overview. Just a question, if I may, that comes up as I'm listening to you, and you're talking about psychiatric care during operations, emphasizing leadership. But just since we have so many mental health professionals here on the call today as well that may be dealing with combat casualties, and I'm just thinking about what we often have talked about. What if a soldier feels guilty for leaving his troops behind because he or she has been injured, and they cannot support their troops? So the guilt, like, I have left my unit, my battalion alone. What would you tell?
So it's funny, this came up a few sessions ago when we had Bob Orsano. So I think the important thing is to be very careful with using the word hero, right? Because that puts a burden on people. But there's an example that I shared after one of our talks that I witnessed in Afghanistan, where a very wounded American soldier, I think he had lost maybe one leg or two legs, he woke up in distress just as he was about to be evacuated. And there was a major, a black, very, very powerful black woman nurse that was there. And she looked him in the eyes, she shook his hand, and she goes, "Son, your war is over. Thank you very much." Right? So I think it really is this, don't put the burden of being a hero on them, but just help them to accept the fact that they've contributed in the best way possible to their, and again, this is where being in uniform helps versus being a civilian. But they will feel guilty, but I think it goes to the acceptance piece, right? And I just think but I think don't burden them by calling them a hero. Don't burden them, because a hero doesn't get hurt. I mean, they'll have all kinds of negative burdens, and there's some link with suicide and all this stuff with that pressure. But I just think really just acknowledgement, acceptance, and this is the piece.
Right.
And there may be guilt, there may be shame, there may be anger, right? When we talk about the moral injury. But again, this is why, to me, this is why I kind of feel the need is going to be even greater afterwards than during, right? And afterwards for one person could be today, afterward for somebody could be 5 years from now.
Thanks, Rakesh. We have a question in the chat, but before going there, I made a few observations. Gonzalo from Argentina, or Amalinda from Albania, or Lubov from Kharkiv, or Oksana from the Netherlands, or maybe even more so, Olga from Ottawa, at the same location as where Rakesh is currently resided. Please call out if you have a question for Rakesh, and specifically Olga, because Olga is located at the same location in Canada, same time zone as Rakesh. But while you're thinking about your question, perhaps the question that is in the chat.
And we have one hand from Andriy. We have one hand raised from Andriy.
Yeah.
Sure. Let's go first to the question. Emotional regulation. Could you advise on knowledge? Simple steps what every psychiatrist can use. A book, an internet page. Any references that you could?
Yeah. Well, I mean, again, so for me, again, I mean, maybe we can send the link out later. But for us in Canada, we really committed to this road to mental readiness. Which comes from sports psychology and performance psychology, and it really has to do with sort of tactical breathing, monitoring your self-talk, because that self-talk can happen. And when you think about it, the quickest example I can give you, when you think about athletes, when you think about a diver that's about to do a dive in the Olympics, or a gymnast, look at what they're doing just before they do it, right? They regulate their breathing, right? They close their eyes. They visualize the thing happening successfully. Then they change their self-talk from doubting themselves to, I've done this 1,000 times before, I'm ready, right? So the idea of regulating the breathing, positively visualizing the event itself, regulating your self-talk, smart goal setting, all of these things. So I think these are, and the problem with lots of these things is it's very difficult, like in the middle of a match, in the middle of the biggest event. This is stuff that ideally you learn ahead of time. And so what we've done in the Canadian military is we teach this during basic training, and the leaders emphasize this with the troops. And this is what snipers do. This is what all of the elite athletes do. So when you tell soldiers this is the same thing that elite athletes are doing, they love it. When you tell elite athletes this is what soldiers do, they love it. So this is kind of our way of selling this. But I think that simple skill, because soldiers are used to learning something, practicing it, then deploying it, right? So we can't get too, clinical setting is different. You can teach people mindfulness, you can teach people these things. But when you're trying to teach a population, it's best to sort of instill 3 or 4 skills. They may not work for everybody, but they'll work for most people. So this is, so we could distribute, the Road to Mental Readiness, there's an app. Eric's been involved with the app as well. And so that would be the kind of approach. So sports psychology for the masses. Clinically, it's different. Clinically, you can go for mindfulness, you can go for neurofeedback, you can do all these kinds of things. But for the masses, I would advise a general approach using some performance psychology or sports psychology.
Thanks. We'll go to Andriy Karachedskiy. Andriy, you raised your hand. Please go ahead.
And please introduce yourself.
Yes.
And you're muted. Perfect.
My name is Andriy Karachedskiy. I'm a psychiatrist, a medical doctor, an instructor in CBT, and a supervisor. I taught a lot. I taught a lot about psychiatric care, but at the moment I am just a doctor at the health services of the Ukrainian Armed Forces. My question is for Rakesh. 2 questions. How do you maintain confidentiality in this setting? On the one hand, you need to register everyone who comes to you. And
Yeah, this is.
I think you're frozen, my friend. I can start with that one
With the
first.
first question, Rakesh. Yeah, how do you remain?
So confidentiality is oh, I can start with the confidentiality one if that's okay, and then we'll. So I think that's an excellent question. I mean, in the sense, and again, every country is different. Every country, and the US has different confidentiality rules. In Canada, you know, we have very strict confidentiality. Our former Surgeon General used to say the confidentiality is our cornerstone. When I first joined the military, a commanding officer could walk into the medical center and say, show me the file from my soldier. That stopped in the 90s. So now we have confidentiality. So the chain of command, the leadership now understands that all they can get are people's limitations, like what they can't do, the prognosis for how long, right? So I would, so if I feel somebody has severe depression and I need to keep them inside the wire and not let them go out to combat for a couple of weeks while I try to keep them in Afghanistan, I would send back in writing. I wouldn't say what the diagnosis is. I wouldn't say what my treatment's going to be, but I would say Corporal Bloggins has, for the next 3 weeks, is going to be confined to the back, to the thing. He can have his weapon or can't have his weapon. He has this, he has this. So again, it's going to be, each country has its own policy, but I would never disclose the diagnosis unless with the patient's permission, right? Sometimes the patient says, I don't care if my boss wants to know, and then we have a talk. But otherwise, I think it's really important. Now, there's no secret. It's a camp. They know you. They know they're coming to see you. There's a little bit of license, but in terms of the actual diagnosis, treatment, we were able to maintain that. The Americans, on the other hand, have this concept called command-directed assessment, where their commander sends you, and you're supposed to give a report with the diagnosis to the commander. I actually refused to do those. I just said I'm not going to do that. So every country is different. So. But I do believe, having deployed twice to Kandahar, looking after many people, suicidal, all of this stuff, we managed within our Canadian troops to be able to look after people, get them better without having to divulge their confidentiality.
Thanks. Andriy, you had a second question that you were frozen when you were starting to report your second question. Could you elaborate on that second one?
My second question is about suicide prevention.
Yeah.
Who are the gatekeepers? Who are the people who can have the idea that a service member might commit suicide, and in what way? How are they trained?
Yeah, I think that's a beautiful example of how, as mental health professionals, we are probably the last line there. We're important, but we're the last line. So basically what we do is, in our mental health education and training, we teach people to understand what's happening inside themselves, then to observe to see what's happening in their peers, and then the leaders have the responsibility to sort of know people. So it's a bit complicated. I'll try to say briefly as possible. Is if you lower the stigma enough, if people feel suicidal or feel terrible, they will share that with a friend, they will share that with the chaplain, they will share that with their boss, or they will share that with the doctor. So reducing stigma, realizing that distress can occur to anybody, and if you're distressed, take a knee, raise a hand. I think that's the important piece. I think that then the people that they share things with, the peers or the leaders, have to have the confidence and competence to have that discussion. And it's not to become the person's therapist, but just to be able to provide, if they need to know what resources are available, this piece. So I think it's a complicated cultural piece, but I think the first cultural piece has to be to reduce the stigma of mental illness. And then after that, encourage people, if they reduce that, to share when they're distressed.
Yeah, briefly,
Він
yeah,
дізнається, командир, про
Where would the commander find out that? How would he know what to do? How would the leader know what to do? Are they being trained?
Well, in
Oh,
in our military, yes, they're being trained, and so the idea, the idea is to address what's going on in terms of you know, if they hear that somebody's suicidal, they have the discussion. But often it becomes knowing what resources are available, knowing that you're there or the chaplain is there, this kind of idea. So again, it goes on that continuum. It goes on that continuum. Like if somebody's upset because they, you know, a friend of theirs has died and they mention it and there's concern, then we do allow the commander to have that discussion with the person. If the commander has any concerns, then we often use chaplains a lot in our military as well. They actually deploy with the troops and go out. But then chaplains, doctors, psychologists, psychiatrists are all available. But we do allow the commanders to have some sort of license as to who has who they're going to send.
Okay, thanks, Rakesh.
Дуже,
Andriy, you wanna make-
ду-
yeah, a last
дуже
comment?
дякую. А можна
thank you so much. And may I ask the third question also for
Oh,
Rakesh?
Okay,
In-
last question then for now. Go
In
ahead.
Canada,
Yes, go ahead, Andrei.
You're muted. Okay.
як саме в
how
канадській армії
exactly? How is decompression affected in the Canadian Army? Is there a concept of decompressing?
Yeah, we do the third location decompression. And during Afghanistan, and again, the science behind it is iffy, but what we do is that the commander makes the decision, not the doctor. And if the commander feels that his troops, and for us, it was 100% of the time they felt that, if they feel it. So what we did basically is, because we do the expeditionary battles. So when I went to Rwanda, you know, we're thousands of miles away, but you could leave Kigali and 18 hours later be in Ottawa. Like it was almost too fast. So what we did from Afghanistan is we basically took everybody to Cyprus. And Cyprus was a place that Canadians are very familiar with because we were there peacekeeping. We basically took over a resort for about 3 or 4 days. We let people have a couple of drinks. We let them toast to their fallen comrades. We let them, you know, eat normal food. And we gave some mental health education. We had social workers there. We had chaplains there, doctors there. And basically that 3 days of decompression, that buffer between a war zone and being home to their families. So that's what we did. I know the Dutch, you guys use Crete, Eric?
We did.
Yeah, the Dutch used Crete. The British used a British base in Cyprus for a much shorter one. The Americans never formalized it. So it's one of those things where, like, sometimes I feel science, you don't need to have science for everything. It just kind of made sense to slow it down. And as somebody that deployed, and all of a sudden, like, you know, 12 hours later, I was home. I know how sudden that can be, and it sometimes is too sudden. So I support the idea of sort of being in a third location, being able to lick your wounds with your colleagues, and then going home. I believe in that.
Hey, Rakesh, last question, maybe briefly, less than 1 minute or so, and then we're going to turn it to Orest.
Of course.
How long would you, and I know this is theoretical,
Yeah,
but here are
yeah.
people that are in the practice, in the
Yeah.
trenches,
Yeah.
in the east of Ukraine. How long can a soldier survive in these trenches when there's bombing every day? What is the, how long can somebody sustain? What do you think?
But yeah, no, I mean, this is where we almost have to go back to World War I. I mean, you do need to rotate people back. You do need
How
to
long?
rotate people back. You know, I mean, it depends. I mean, Andrea may be able to talk about the reality. It really depends on, I mean, I don't think a human being can stay on, you know, for more than 12 or 14 hours. Like, I think, you know, so the question is that when do you feel safe? When do you fight? I think that's important. That comes out of sports, that comes out of, you know, you look at airline pilots, you look at all of these things. So I just think that, I think the idea of rotating troops in and out, even if it's a couple of kilometers back, I think those are important principles that we've known. I mean, the Romans knew that. I mean, this is stuff that's there. So I just think, you know, the actual perfect answer I don't have, but I think what it does is it gives people hope. it gives people a chance to sort of, maybe go back and eat some normal food, go to sleep without one eye open. I think those are really, so troop rotation is extremely important, even in the worst battle.
Thanks for the recommendation, Rakesh. Now I see so many greetings on the web. Oksana said hi from the Netherlands. We can see you, and Olga did say hi from Ottawa. So thank you for chiming in the chat. Hi, Ottawa. It's a pleasure to see so many faces, and my heart starts to beat when I see all these greetings. This is why we do this, to bring the expertise to you. And I'd like to turn it now to Irina, who will introduce Orest Suvalo, I'm sorry, to introduce him and to spend time with the current situation in Lviv and the Ukrainian perspective, so to speak, on what's going on. And he has some interesting insights that he would like to share with us. So Irina, would you like to introduce Orest? We'll stay on for another quarter of an hour. So it's now at the top of the hour, and we'll continue typically till a quarter past the hour. And that's about wrapping up time.
Yeah, but probably we would have several minutes extra.
Okay, that's fine for me, or fine for all of us, I would guess. But that's about the time that we're starting to close the session. Maybe we'll go up to 20 minutes after the hour.
Yeah, so it's my pleasure actually to introduce a dear colleague of mine, Orest Suvalo, who is adult psychiatrist, and he is a coordinator of community-based mental health services development at Mental Health for Ukraine project. He is coordinator of project at Institute of Mental Health of Ukrainian Catholic University, and currently he is a co-chair of Lviv region local mental health and psychosocial support group. Orest, please.
Okay, and Rakesh, you will stay with us, right, for the discussion afterwards, right?
Oh, absolutely, I'll stay as long as needed.
Excellent.
Thank you, Irina. I will shift to Ukrainian language. It will be much more quicker. Добрий вечір, колеги. Дуже дякую, Ірині.
Good evening, colleagues, and I really appreciate that I was invited to this event. I always valued and treasured these events. I attended the previous ones, and this one also. We've had a great presentation by Dr. Rakesh, and I was first surprised because I'm not a military psychiatrist. I am a regular civilian psychiatrist, and now I work with community-based services, but we all are in this or that way dealing with the service persons. We see the veterans who come back, and we have to respond to the questions they are asking. So I've been thinking about something I could present today. And by the way, I also wanted to express my appreciation to the colleagues from Mykolaiv and Kharkiv. We hope everything is all right. We are also having the fingers crossed for you, and huge respect that at this time you continue your development and training, and we are all together. So if we talk about the military, it's important to understand that what we are doing now in communities, they will be also used for the military who will be coming back. So also working in the humanitarian context, I can see the results of the previous project with the communities in terms of general awareness, engaging different stakeholders in the communities, the GPs, health providers, social workers, and I see how it's different in those communities where we've had mental health awareness campaigns. So to summarize, I would say that there are several things which are not difficult, but they're very needed. And still, there's a lot of things to learn. And Irina helped us organize these hot topics. And essentially, in some ways, like Western weapons delivered to Ukraine, we get knowledge and we can master it and apply it in Ukraine when necessary. mental health in Ukraine is full of gaps, and we see these gaps which exist, and they are still a serious barrier to getting care. From what I see, that there are guys who get some issues or who have disorders, but they cannot get help from communities, especially from remote communities. And this is about the lack of rehab services and also occupational therapy. Unfortunately, it's not yet in the package of basic services which the GPs are providing, because according to Ukrainian legislation, rehabilitation and occupational therapy is only provided by psychiatrists in the context of mental disorders. But we need to provide comprehensive care. We need to engage social services, NGOs, to provide really comprehensive approach. So if we talk about things which Eric mentioned, the recovery, overall, the recovery-based approach is still a terra incognita for many specialists here. They don't know much about it, but essentially we have to share the best practices which are routinely used elsewhere, and to make them known and available for the bigger public. Still, we have quite a lot of achievements too. Since 2014, we have this war, and we've been trying to develop throughout all these times. 2017 and 2018 were difficult years for the health system. It was the beginning of the health system transformation. You know how difficult it is, how drastic were the discussions, and then COVID struck. And still, I mean, back then, even mental care and mental health were part of the strategic vision. So the concept and the action plan were developed, and now we see how relevant this topic is. And we know that now it's also discussed at higher levels. We know there is the initiative by the First Lady of Ukraine. Also, the Cabinet of Ministers of Ukraine has created a cross-sectoral work group on mental health. So hopefully we will have very tangible results from all this. But when we talk about the military, I think perhaps Andriy Karachedskiy would know more about this, because it is still kind of a restricted topic or a closed topic. Of course, there are some grounds for that, but I'm sure there are many growth points for the military mental health too, and probably military psychiatrists would know more about this. But if we talk about the communities and things which could be done at community level, so that we will be prepared for all the veterans coming back to the communities. We have chosen this tactic of providing mixed training for all the stakeholders, the GPs, the social workers, and community representatives, so that this awareness would be cross-cutting. And also, we are always having the question, so people who work as psychologists, as doctors, do they know any veteran services in their communities? And even if these services are there, very rarely local stakeholders know them. But only in the context of learning, in the process of learning, in the process of studying mental health, and it still is highly stigmatized issue for the many. But after some time, people slowly start discovering that the services are available, and they start referring their patients there to these services. So it's all about the communication. It's about knowing what's already there and what is still missing. And this will help us develop the comprehensive approach. I won't take lots of your time. I just wanted to reiterate these basic things, and there are still many things to be done, but the ministry really needs the assistance of all of us, because good proposals, especially put on paper, would be very relevant. I think now we have to focus on three main directions, and it's great that the expert community is growing, and these three directions are, first of all, education, formal education for the heads of structures, including the military structure. So it's not just some NGOs doing the training, and I understand that NGOs are now doing a lot providing these trainings, but they have to be routine. It has to be routine formal education. So awareness raising and education, these are really necessary to move on. And I appreciate Irina's efforts, because this is one of the ways we can get education. Also, coordination, because I see it often in the humanitarian dimension, that very often the coordination is lagging behind. There are several centers of coordination. There's many overlapping, and there are, let's say, gaps. For example, for the IDPs in Ukraine. So coordinating all the approaches would help us all to be efficient and effective, and we will be able to use the resources in the most optimal way. And the last thing, which is very important and which would be needed in the future, we tried doing this with Ms. Irina and with Andriy a few years ago, and it's about forming the network of specialists who are competent and who can represent some power which can affect the decision making at different levels. Forming these networks is very important. It's growing well, so I hope our communities, our networks will get stronger and stronger, will master evidence-based approaches. They will learn from international best practices and Ukrainian best practices, because in the current environment, we are getting quite a lot of knowledge and experience which others would treasure too. Yeah, unfortunately, we have to pay the heaviest toll, but it brings us experience. So these networks, coordination, and awareness are three basic pillars upon which hopefully we would be able to grow all together. And I appreciate once again, thanks, Irina, for giving the opportunity to express these ideas. Glory to Ukraine.
Thank you, Orest, and for these three pillars that you eloquently described to us. Now, in the conversation that was just at the beginning of this webinar, you also spoke about the 260 mental health evacuees that came from Kharkiv, just today arrived in Lviv, that I understand puts a lot of pressure and also calls for creativity, because that's an incredibly high number, an increasing, impossible demand, I would hardly say, on the creativity of the professionals dealing with those situations. Could you say a few words about that, if you wish?
Насправді, ми розуміємо всі, що ми живемо в війні.
We all understand that we are now living in the situation of the war, and quite a lot of things, they cannot be predicted. So people, of course, are fleeing to safer locations, and it's often very difficult to coordinate who goes where. Lviv region is at the western border of Ukraine, and it's now full of people, especially elderly people and people with disabilities, those who get to the region. And it indeed requires a very creative and flexible approach, and it's not easy. So locally, we are, well, doing the best we can, and it's not easy.
Дякую, Oreste. Thank you, Orest. And before we will stop, I would like as well to call Andriy Borisovich to share his as well expert opinion on the topic we've discussed today. Yeah, thank you, Andriy, if you would be able.
Дякую.
Thank you. Well, to recap, I'm not speaking as a psychiatrist now. I'm more engaged in tactical care. But yeah, of course, I have the skills of the psychiatrist. They're always with me. So sometimes you see acute stress response, and you understand you're trying to find ways to deal with neurotic manifestations, some depressives, but when we talk about things which would be great, which could be improved in the military, I would say we lack structure in the organization of mental health in the military. So we need structure in terms of mental health and rehabilitation. Now, as there is this well, massive need since the February invasion, quite a lot of people are now at the front lines. And there was no screening, there was no preliminary assessment of the service members. So now quite a lot of work is required to find the best job for the soldiers. So in the subsequent waves of drafting, hopefully it would be possible. And the new conscripts would also get the appropriate training. They would get trained in first psychological aid. It's an important component in combat cohesion and all other things. Another important thing is that in the civilian life, we have quite a lot of specialists who can work with traumas, who have good skills, and like I am the head of the mental health center for trauma therapy. So these centers are highly specialized, and they're aimed at work with patients with severe trauma. But now, when we have the military aggression, there are quite a lot of people who are no longer providing care for some payment, and they are just volunteering in providing care, and they have the burnouts. Another factor is that we have the military and the civilian structures very separate, and they're very distant from each other, unlike Israel, for example. So this also needs to be resolved somehow. And when a person becomes a veteran, they would need to continue getting care, but in the military, if they're still enlisted, it's difficult to get psychotherapy. Unfortunately, we don't have enough specialists and enough centers. We need to develop this and to improve this. So this is rather a task for us all.
Thank you.
Thank you, Andriy. I know what
Maybe
Maybe you have
Lena,
questions.
but maybe
I
I
can
would like
answer.
to give the floor to Rakesh Jetly, just briefly also to reflect on the things he heard, or if he wishes to comment on
Yeah,
some of the
no,
things.
I mean, Andrea, thank you. I mean, it's an absolute pleasure, and I love what you're saying. I mean, you're involved in tactical. You're not sitting there doing psychoanalysis. You're trying to keep people well, trying to keep the fight. You're trying to win the war, and I think that's exactly. I mean, you've summed up what I've been trying to say. There was a comment in the question of who pays for this, and most of our Western countries, Canada, US, Australia, the Netherlands, I mean, veterans are looked after, paid for by the government. You know, the British doesn't have a Veterans Affairs, they have a national health and they have charities. So there isn't an expectation in most of our countries. There isn't an expectation in most of our countries that veterans pay for their own care. And I fully believe that. I think that, you know, a grateful nation should look after its veterans. I mean, so I think that was the other point I want to make. And I just, again, thank you for this. What a great meeting. It always gets me thinking. And I know Eric, we're going to talk in an hour. We're going to get a chance to reflect on this as well.
Yeah, thanks, Rakesh. Orest, you wanted to comment on what you heard from Andriy, or in general?
Дякую. Мені складно, Андрія,
Thank
коментувати.
you. I struggle to comment on Andriy because I know how things stand, and Andriy has even better knowledge of that. So hopefully Andriy would be able to put together a team to rectify the situation, because training and providing care during the active service is a problem. I like working with the veterans. Here, some progress is in place, thanks to Andriy inter alia. So I support Andriy. Thank you for doing that.
Yeah, thank you, Orest. And you stress the structure in the mental health in the military, Andriy. That's a message you very heard, and that there's leadership that is involved in that. And actually, it's all of us who are the experts in the field of mental health to see if we can find ways to support providing you the tools or the building blocks for providing you with that structure.